One particular place where aneurysms manifest is in the aorta. These are dilations of blood vessels that are marked by weakening of the vessel walls. In the aorta, they are typically found in the abdominal aorta as a result of atherosclerosis, but they can also be found in the thoracic aorta in hypertensive patients or those with Marfan syndrome. Note also that aneurysms can be commonly found in the brain, and that is discussed in greater detail in the neurology chapter. The next important cardiovascular pathology to recognize is aortic dissection. This occurs when there is a tear within the intima of the aorta, producing a false lumen which blood can enter. This is a life-threatening emergency. Patients will classically complain of severe tearing chest pain radiating to the back. It carries with it a high risk of mortality, either due to aortic rupture, which is rapidly fatal, or due to other causes such as hemopericardium leading to cardiac tamponade or even occlusion of the cardiac vessels. In the CT image shown here, we can distinguish the true lumen of the aorta from the false lumen of the aorta, separated by an intimal tear. Now let's move on to talk about ischemic heart disease, which is arguably the highest yield cardiac pathology that you'll need to know on the exam. In general, this is heart disease that results from cardiac ischemia, usually due to poor blood flow as a result of atherosclerosis. There are many different manifestations of ischemic heart disease, and part of the danger is that one can change into another without any warning. First is angina, technically known as angina pectoris. This is chest pain due to poor blood flow. In the stable state, the coronary vessels are narrowed a fixed amount, and rest or nitroglycerin relieves the symptoms. In the unstable state, chest pain persists despite rest, and nitroglycerin tends not to help. These two types of angina can also be noted by ST depressions on an EKG. Finally, Prince-Metal's angina occurs due to coronary artery vasospasm, often in the setting of cocaine use. Another important concept is coronary steal syndrome. This occurs when a vasodilator, such as nitroglycerin, actually worsens chest pain, and it happens because natural collateral blood vessels that have formed to perfuse the heart are deprived of their blood flow as blood flows into other areas. The most dreaded of the ischemic heart diseases is a myocardial infarction, commonly known as a heart attack. This occurs usually due to acute thrombosis of a coronary artery and leads quickly to myocardial cell death. Within 1 hour, this can lead to sudden cardiac death. This typically happens by means of a lethal cardiac arrhythmia, such as ventricular fibrillation or VFib. Finally, ischemic heart disease can be more chronic, resulting in a slow decline in heart function over time and eventually heart failure. Most people already know the symptoms of a myocardial infarction, or MI, but it's important to review the pathology behind it as well. The classic presentation of an MI is crushing substernal chest pain, radiating often to the left arm or jaw, as well as shortness of breath, fatigue, and sweating. However, it's important to recognize that some patients, such as women and those with diabetes, can frequently have atypical presentations involving radiation to the right or even radiation to the back. Another important thing to remember is that the LAD is the coronary artery most commonly affected, then the RCA, and lastly the circumflex. This fact goes through the pathologic findings that would be seen in the time after an MI. We won't go through all the details, so it's important to mark this page to review on your own. However, let's highlight some important points. Pathologically, it's important to remember that the first changes appear after a full 4 hours, and that the first detectable cardiac enzymes appear in the blood after 12 hours. Then, as the inflammatory reaction takes place, there is a period of great weakness around 5 to 10 days. In the long term, this is followed by a scarred area of myocardium. In terms of clinical risk, the most important early risk is arrhythmia. In the 5 to 10 day period, weakness of the wall predisposes to rupture of the myocardium itself with ensuing tamponade, or rupture of the papillary muscles, and in the long run, there may be an akinetic section of the myocardium that predisposes for ventricular aneurysm. In order to diagnose MI, clinicians rely on several important tests, and you'll definitely see these being used on your clinical rotations. Within about 6 hours of the onset of symptoms, the gold standard is an EKG, because there aren't many pathological changes that have taken place yet. EKG changes include ST changes, including elevation or depression, as well as pathologic Q waves. Troponins can be used after about 4 hours, and these are quite specific for myocardium. CKMB can also be useful, but it is less specific, and therefore it is best for diagnosing a reinfarction. Theoretically, AST could be used, but clinically it rarely is because it's so common in other cells, especially in the liver. Since MIs are so serious, it's important to distinguish two important types of MI, transmural versus subendocardial. As the name implies, a transmural infarct is one that affects the entire wall of the heart, leading to severe necrosis as well as ST elevation. On the other hand, subendocardial infarcts involve only the subendocardium, which makes sense. This region is particularly vulnerable to ischemia due to the nature of its perfusion. This results in much less necrosis and generally correlates with ST depression on EKG, so these two are fairly easy to distinguish from one another. As we mentioned before, pathologic Q waves can indicate MI in addition to ST changes. The locations of these Q waves can actually give insight into the location of the MI. This is a very important and high-yield table for the exam, but the rationale behind these descriptions is beyond the scope of this discussion. Please be sure to mark this page to memorize which leads are associated with which arteries. As we've already talked about, MIs can have a number of deadly complications, so let's go through now and review them all. We've already mentioned arrhythmia, which can be fatal in the first few hours after an MI. Next is left ventricular failure and resultant pulmonary edema, largely due to the decreased ability of the heart to pump out blood. Third is cardiogenic shock, where the heart pumps so poorly that the blood pressure cannot be maintained, and this is a really serious condition with a very high risk of mortality. Fourth is rupture of the free wall of the ventricle, leading to tamponade, or rupture of the papillary muscle, leading to severe mitral regurgitation. There can even be rupture of the interventricular septum, leading to a VSD. We've already mentioned number 5, ventricular aneurysm formation, and that can be associated with mural thrombus formation, and that can eventually lead to embolization and even stroke. The last two are actually immune-type reactions that can result from an MI. The first is post-infarction fibrinous pericarditis, characterized by a friction rub heard 3 to 5 days after an MI. The second is an autoimmune fibrinous pericarditis called Dressler syndrome that occurs several weeks after an MI. Now that we've finished talking about ischemic heart disease and MI, the next big category to go over is cardiomyopathy. This is a very high-yield topic on the exam because there are a number of different etiologies that can contribute to cardiomyopathy, so let's begin to go through them. The first is dilated cardiomyopathy. This is the most common, and it results in a dilated heart due to eccentric hypertrophy, meaning that sarcomeres are added in series. There are a number of different etiologies, all of which are listed here, but the most important ones to remember are alcohol abuse, beriberi, Coxsackie virus, and doxorubicin toxicity. The next category is hypertrophic cardiomyopathy, where the heart enlarges due to hypertrophy. This is a genetic condition where the interventricular septum partially obstructs the left ventricular outflow tract. This can result in sudden death in young athletes because increased ventricular function can abruptly block off the left ventricular outflow tract entirely. The third and final category is restrictive cardiomyopathy. You can think of this as cardiomyopathy that results from some foreign material accumulating within the myocardium, and it is seen in diseases like sarcoidosis, amyloidosis, various types of fibrosis, and hemochromatosis.